I'd like to start the meeting and welcome Paul Griffin, who's known to most of you, local infectious diseases specialist, Mater Health Services, Head of Masters Clinical Unit, Doctor to the Brisbane Lions, Professor of University of Queensland School of Medicine, and a board member. Paul.
Thanks very much, Rod, and thanks for the invitation to speak today. It's great to see all the people are truly at the front line of vaccination together in one place to try and solve some of the big challenges that we see at the moment. A few disclosures, but basically the content of what I'm going to present today is my own and not influenced by any of those. I've got an outline that makes it look fairly crowded. A lot of these are there just for context, and we've got some other great speakers that are going to go into more detail for some of these topics. So I will skip over some of them fairly quickly, but as I say, they'll be covered off by other speakers who are coming up later on. So who are the at-risk populations for vaccine-preventable diseases? We hear this term a lot and it's fairly non-specific. So I thought I'd just go into some of these. And obviously, a lot of these concepts overlap quite a bit, but there are a number of ways people can be considered at risk for some of these diseases. They can have an increased risk of infection due to being immunocompromised. Their frontline defences aren't necessarily functioning to the full extent, or also maybe increased risk of exposure. So these are people that might have either an occupation or reside in a location where they're more likely to come into contact with some of these diseases. And of course, residential aged care is a good example of that, but so are healthcare workers. And you can see at the bottom, I've mentioned there that guidelines try to accommodate most of these, but, for example, healthcare workers are often not necessarily included in some of these guidelines. They can also have an increased risk of severe disease. Once again, immunocompromised features there, but they can have comorbid conditions that also increase their risk of progressing to more severe disease if they get infected with one of these. And they also may be less able to respond to the vaccines themselves, so don't get the same level of protection that most of us enjoy from receiving these vaccines. And interestingly, older age essentially incorporates all of those, and I'll talk about that briefly, and I think we've got a speaker coming up later who'll go into that in a little bit more detail. And while there's a lot of overlap naturally from some of those, the risk isn't necessarily the same for all of these diseases. And I think the flu versus COVID is a good example of that, particularly with what we see with young children with the flu, not necessarily the same with COVID. So there are also some less obvious risks. So you'll see in a lot of our guidelines, it incorporates Aboriginal and Torres Strait Islander people, and even people who are culturally and linguistically diverse who seem to be affected to a greater degree by a lot of these diseases for reasons that are not necessarily included in those three that I mentioned above. And as I say, our guidelines incorporate most of these, but you can see some of them simply can't incorporate all those factors. So that's why we need experts like those in the room to be able to make recommendations based on some things that aren't always included explicitly in those guidelines. I think most people will be familiar with the concept of immune senescence. So we know that our immune systems, like a whole lot of things, unfortunately, start to not function quite to the same degree as we get older. And you can see here I've listed quite a few things there as to why that might be the case. But we know essentially those three things that I listed in terms of why people might be at greater risk apply to people as they age, particularly because their immune systems don't defend against these pathogens quite so well, but also their ability to respond to vaccines may not quite be as good. And fortunately, these days, though, we've got advanced technology that does help to address some of those limitations. So you can see at the bottom there, we have high doses, adjuvanted vaccines, or even recommendations for more frequent boosters. But unfortunately, we're perhaps not meeting that recommendation at the moment. And I'll obviously go through that, particularly with COVID. Of course, as people age, they also accumulate comorbidities. And you can see I've got some figures there that, 4 out of 5 Australians over 65 have at least one chronic condition. There's obviously then also exogenous immune suppression as people will start to accumulate autoimmune, inflammatory or malignant processes for which we need to further suppress people's immune systems. Residential aged care facilities, I'll come back to a few times, because not only do we house the highest risk people there, but we have trouble controlling and limiting exposure in those sort of facilities. So that, I guess, compounds that risk even further. And then some things that may not be obvious in terms of being a risk for worse outcomes with these sort of infections. Frailty is a big factor, and often something that's further exacerbated if people get these infections. And I think interestingly with things like RSV, when we're looking at cost effectiveness, etc., people not returning to the same functional status after having one of these infections is something we need to consider and is hard to measure. But even cognitive decline, malnutrition, for example, are also factors that can be present in this sort of a population that make the risk of these diseases far worse. And you can see some figures there. So we know that with the flu, while it does certainly impact young children very significantly, the majority of our deaths do occur in this population. Oops. And so what are the diseases we're talking about of greatest impact? And obviously there's a lot of vaccine recommendations for the elderly. We've got shingles vaccination, for example, pertussis, that I won't touch on in great detail. But I guess the big three that I'll focus on are obviously COVID, flu and RSV. And here's the cases from this year. You can see and I think everyone in this room will be aware, we've had an exceptional flu season, perhaps the highest on record, around 410,000 cases reported. And you can see there, and being mindful that axes of these graphs are a little bit different. We're approaching 1,800 cases in our highest week with the flu. But what's different to the past, and something we obviously have to just become used to dealing with now, is the overlapping COVID wave that we also saw in winter, and of course lots of RSV as well. And I'll talk about our increasing understanding of RSV in a moment. So obviously that's a lot of cases occurring across our winter periods of all three of those diseases. And just by way of an indication of severity, if we look at hospital admissions, you can see here flu in blue, obviously a very large number of people admitted to hospital with the flu, particularly in the winter months. You can see RSV also, quite a high number of admissions, and COVID, and it's still debated as to whether we've established an element of seasonality with that, but seemingly increasingly likely to have two peaks a year in the summer and then also in the winter. And again, as another measure of severity, we've got ICU admissions, and this is not just the three vaccine preventable respiratory viruses that I'm focusing on, but a few others as well. The flu obviously was overrepresented there, particularly as you might expect in winter. But also COVID and RSV also contributing quite a lot of admissions to intensive care as well. And if we look at deaths, and again, this is a little bit complex, and again, the axes are quite different. So while we saw that cases and even ICU admissions seem to be greater for perhaps the flu, particularly this year, COVID is still very much overrepresented when we look at deaths. And you can see less so than previous years, with the dark blue being this year. Still quite a few deaths due to COVID. So I think in the highest month we're at 76 with flu, 51 this year, and seemingly maybe more deaths last year than this year, while our case numbers seem perhaps higher this year. And I think, RSV, we're still trying to convince many people that it's a significant virus in its own right as well. You can see there's 73 deaths from RSV in July this year as well. So that certainly carries a significant burden of disease. And just looking by age, and these are figures from last year, just showing that COVID has the greatest spread of age. So you can see, while it's obviously associated and the increased risk is greater in those that are older, we still see deaths even in younger populations with COVID, and about 4.5 times the deaths last year from COVID than there was from the flu. So if we look at our COVID vaccine coverage and look at COVID in a little bit more detail, this graph's obviously not that helpful in many ways. We've obviously seen fewer cases in recent times than we did early on, and doesn't necessarily show a seasonality or anything too useful. But I think it's useful to look at the outbreaks in aged care. We've got great data from aged care. Not only is it the population that's perhaps highest risk, but we get good data from that. At the top, you can see the number of outbreaks. And while we talk about it a lot less and case numbers seem a lot less, there's still significant numbers of outbreaks in residential aged care, even during the most recent wave over winter. You can look at trends in cases, and there's residents as well as staff. And again, even recently, there was still a significant number, not as many as a few years ago, but still a significant number. And you can see that deaths in residential aged care facilities are overrepresented there in that sort of darker purple colour. So still a significant number of those coming through. So again, while we're not hearing about it as much, and the case numbers perhaps don't tell much of a story, we still are seeing a significant burden of disease from COVID as recently as 2 or 3 months ago. So the vaccine recommendations, and I won't go through this in detail. Hopefully everyone in the room is fairly familiar with that. We've had another recent change in the terminology. We had consider, changed to eligible, now back to consider. We've only got the one vaccine option at the moment, but that's obviously also something that might change in the not too distant future. And really our COVID vaccine recommendations are based on age and immunocompromise. And so, as I mentioned, things like being a healthcare worker that might put you at greater risk, or particularly if you're maybe working with lots of COVID patients, isn't factored into these guidelines. And again, that's where we need to be able to provide recommendations to those groups who might have other risks. But you can see there for our oldest group, our highest risk group, 75 and older, a recommendation every 6 months, regardless of other comorbidities and other factors. And just to sort of show who is at greatest risk of COVID, I've just cut and pasted the vaccine eligibility, which I mentioned. It focuses on age and immunocompromise. But the eligibility for oral antivirals is a bit complicated, but just lists some other factors. So Aboriginal and Torres Strait Islander people are eligible for these at a younger age and with only one additional risk factor. And you can see there's some other things like living in residential aged care or living with a disability and multiple conditions and frailty. So again, some of those risks that aren't necessarily obvious and may not be included in the vaccine guidelines certainly are significant risks for people getting more severe disease from COVID. And so if you look at the overall figures, it probably looks like a bit of a success story. And I think our rollout early on, and again, a bit controversial, was largely successful. So 75 million doses administered in total and a population of about 27 million, so about 3 each. So that's pretty good overall. But if we look more recently, I think it's a little bit concerning, to be honest. So again, it's hard to pull out an overall figure given our recommendations are quite different depending on what population. But if you look in the last 6 months, those people 75 and older who should get a vaccine every 6 months, ideally, we're looking at even less than a third of that group have had a vaccine in that time frame. And if you look over the last 12 months, and again, people in that slightly lower group, 65 to 74, who would be recommended to receive a vaccine every 12 months, we've got 27.4% of those have received a vaccine in that time frame. And again, a lot of people say, oh, the risk has gone away, there's not much COVID around. But if you recall those figures about residential aged care outbreaks and deaths in that group, it's clear that COVID does remain a risk. So having just over a quarter of that group vaccinated, I think, is certainly not ideal. And if we look at that highest risk group, residential aged care, you can see that just over half have had a vaccine in the recommended time frame in the last 6 months, which, given the risk of people in that group, given they overrepresented in terms of all the bad things COVID does, I think that's nowhere near enough. And if we look quickly graphically at when our doses have been administered, there have been a few little peaks this year, which is good, I guess. And if we start to think, why has that happened? I think it sort of overlays with the case numbers. And so some of the things that we'll come back to, I guess, is perception of risk. And when you're hearing about COVID and seeing people with COVID, that might encourage people to get a booster at that time. But I guess part of this is how we encourage those rates to stay at a level we want all the time, even when we may not necessarily be seeing those case numbers bump up like that. The flu, again, I think everyone in this room is hopefully familiar with the fact that the flu is not just a cold. That was a bit of chat this year about trying to make sure people understand the actual risk of the flu, because we hear so commonly, oh, it's just if I've had that all the time, doesn't do anything. But you can see here there's a very significant impact from the flu, not just in terms of deaths, but we have hospitalisations, doctor visits, lost work days, etc. So it is a very impactful infection in its own right. And if we look at our case numbers this year, and I'm not sure how well that projects, and you can go to the Immunisation Coalition website and look at all these figures, and it's been discussed a lot publicly. So over 400,000 this year, many saying it's perhaps the highest number since we've had good records potentially, and certainly more than last year. And if you look at the vaccine coverage rate, obviously NSERS have a great website where you can look at a lot of these figures. And here we break it down by age. You can see that we're doing okay, I guess, in that older age group, over 65. Obviously, it's a group that access vaccine nationally on the National Immunisation Program. But as I mentioned, young children are at significant risk of the flu. They're a group also funded on the NIP because we recognise that risk. Unfortunately, our government funds that for them, and you can see that we've only had 25%. So that's last year's. This year, a lot of chat in the media that we're less than last year. In fact, the figures, if I put them side by side, are actually fairly similar. And just because we're in Queensland today, if we look at what's happened locally, and again, the football capital of the country, and likely to stay that way for some time, a lot of discussion about what's happened in Queensland. I think it's been fantastic. Our government has funded flu vaccines for everybody for the last few years. I think that's a fantastic initiative, really important, but unfortunately hasn't translated into an increase in uptake that we would have really liked to see. So obviously, while I think that's clearly important and not up for debate, it's not in itself the solution. And in fact, our vaccination rates here in Queensland for flu have been declining steadily since 2022. So there's more work to be done on that front. And as I mentioned, a lot of media in the last few days, even that this is the biggest flu season on record, but our vaccination rates have stalled. And, obviously it's why we're all here today, and hopefully we'll get some good insights from many of the speakers today about what we might be able to do about that. RSV is fascinating. So if we're doing this 3 or 4 years ago, it would have been a very short talk. We don't really know much about it, and there's not really much we can do about it. But obviously that's changed a lot. And in itself, that's a bit of a problem because it has evolved just so quickly. I think it's been hard for many people to keep up with exactly what's happening. I've had feedback that RSV you've just made up because you don't get to talk about COVID much anymore. It's really not that bad. Kids get it, get a bit of a runny nose. But, obviously, as this data is emerging, we recognise the consequences of RSV and we start to be able to demonstrate the efficacy of these interventions. Hopefully, we'll be able to increase the uptake. And so here's a similar graph just showing the number of cases. If we continue to have a similar number of cases per month for the rest of the year, we might hit the highest RSV season on record, keeping in mind we've only been keeping records for a small number of years. And a similar list of risk factors for more severe disease. So we know that children, particularly premature, chronic heart, lung disease, etc., a significant burden of disease in the very young. And in adults, again, a similar list to the other vaccine preventable diseases we're talking about, chronic conditions, advanced age, immunocompromise, etc. And just by way of listing that out, if we look at some of our interventions that are the recommendations incorporate some of those risks, here's a bit of a list of those so we can just get an understanding of what they are. You can see it's quite a lot more extensive than some of those basic things about being older and immunocompromised. There's seizure disorders, spinal cord injuries, etc. So there are a lot of things that do impact the risk of these diseases that are factored in to a lot of our recommendations. And here, a slide I'm trying to summarise where we're up to. And one of the biggest challenges with RSV is this has been changing very frequently. So it's hard for the general public to keep up, much less people that are doing this every day. So for our oldest adults over 75, we've got 2 options. It's recommended. For people a little bit younger, it's a consider if no risk factor. So obviously the approvals are different to the recommendations, which are different to funding. We have a recent expansion, which is fantastic, to have an option for people 50 to 59 with risk factors. And in pregnancy, again, I think this is one of the big success stories of recent times. We've got an NIP funded option. So we do have a vaccine for RSV in pregnancy. Bit confusing as to exactly the best time to use it because, again, some slight differences between recommendations and approvals, but you can see there. And then in infants and children, again, probably the biggest success story of the things I'm talking about today, we've got nirsevimab, which has made a fantastic difference. And I'll show a little bit of data on that in a moment. So we don't have great figures on coverage. So here I've done a bit of a back of the envelope calculation. So you can see on the top left, in 7 months this year, 110,000 doses. We have about 300,000 births in Australia, so it's about 25,000 a month. So therefore, that would make our uptake very, very roughly about 2/3. Keeping in mind, some people have one pregnancy for multiple children and pregnancy might not translate into a birth, etc. So it's not necessarily accurate, but again, very back of the envelope, but about 2/3 potentially, which is pretty good given it's relatively new. And if we look at immunisation with nirsevimab, again, a fantastic story. This has evolved just so rapidly. So last year, WA implemented a seasonal program. We followed fairly soon after with a year-round program. So you can see there over the summer months, that sort of appropriate maroon-coloured line. Queensland continued to administer a few doses. And then things changed really rapidly at the start of this year with NIP funding and most other states coming on board with nirsevimab. Interestingly, Queensland continued to decline, and hopefully that's because our vaccine coverage shot up. But when we start to look down at that, so this is some figures from where I work, a very large maternity hospital. We've tried to piece together exactly who's getting what and what the rate is. And I think where we're probably going to head is not tracking those as separately, just seeing what proportion of our young babies are protected, whether it be by maternal vaccination or by nirsevimab. And we're tracking along pretty well at our place at around 90%, but those figures are a bit incomplete. We probably are missing some, so it's probably a bit less than that. And you can see there the blue nirsevimab, the light blue, dipped fairly abruptly when we started seeing increased rates of vaccination. But if we track along at 90-odd%, so 90-odd% of our babies are protected by one or the other, I think that's actually pretty good. But we'll hopefully see more granular data coming more broadly as we see these programs roll out more and more. So why is vaccine uptake so challenging? Again, I think this audience will be familiar with these. This is just a list of things I put together. There's probably tens or hundreds more. So I think fatigue, people are a bit sick of hearing about a lot of infections and vaccines because there's been so much the last few years. Complacency, and I think that comes into reduced perception of risk of some of these diseases, an increased perception of risk of vaccines. And again, it's no secret There's lots of people propagating all this sort of stuff through social media. And a bit of a loss of trust in public health has been talked about post-COVID, or post the early days of COVID at least. Complexity. So I think there's a lot of people who aren't necessarily anti-vaccine, but just have trouble keeping up with what those recommendations might be. And I think particularly older adults, now that it's a really crowded space, we're really lucky to have so many options, but it's been a bit hard to keep up. And of course, cost. And so RSV is a great example there. There's always a lag, no matter how favourable the assessment is in terms of getting these vaccines funded. And we're hopefully we'll see that with RSV at some stage. The strategy we're hearing about in more detail, so I won't go through this in any detail myself, but obviously it's fantastic to have a strategy that's come out with some priority areas that I think do address a lot of the issues we're facing. And so I really look forward to seeing how that translates into improvements. And I guess one strategy is improving vaccines. And I think I just wanted to cover this off fairly quickly, because there has been a lot of changes in this area. We've seen new platforms, and again, I won't go through this in any detail, but new platforms coming through. And I think the alternate route to needle and syringe is something that we really do need to be mindful of, because we have a recent advance there with flu mist becoming available. Some studies suggesting up to a third of children might have an element of needle phobia, prohibitive from receiving vaccines in maybe 10 or 15%. So this coming on board next year will hopefully fill a little bit of a gap. And so I'm really looking forward to that. And just because it's a local development, other routes of administration I think are also potentially going to be important. A local company that spun out of UQ making these patch type vaccines, still in clinical trials, but hopefully we'll see that as an additional route coming through in the not too distant future. And just by way of showing what other advances might help us, we have a whole host of improvements we'd like to see, maybe transmission blocking vaccines and other things. This is a bit of a wish list for COVID, but more advances in vaccination, which are coming, will hopefully help with some of these things, as well as combination vaccines. So COVID, flu and RSV, there's many combinations potentially coming. In itself, not a solution necessarily, because we know it's going to be hard to know when to use these and might not necessarily fix all of those challenges, but I think making it a bit more convenient might be one step in the right direction. I think I might be a little bit over time, so just wrapping things up really quickly. It's really clear that our vaccination rates for all these diseases is low. And there's a whole lot of things we can do, but I think we're making some steps in the right direction, and hopefully we'll see that translate into increases in the not too distant future. Thank you.
The one question is, why isn't there a consistent Commonwealth and state, and why are all the states different? Do you have any comments on that?
Look, I think it's a great question, and I think it is a bit of an issue, because not only do we see complex recommendations, across borders, but I think when there's a lack of consistency, it also feeds into a bit of a lack of trust. And if it's so good, why aren't all the states doing it? If it's so good, why isn't it federally funded, etc.? And we have complex systems around approvals and funding. It all takes time, so some of it is just literally a function of time, and some of it is different epidemiology in different states as well, and different lobbying, etc. So a complex answer, but what I'd really like to see an attempt to try and unify recommendations and approvals and funding across the states if we can. And hopefully the way we do that is some states want to take the lead, like WA particularly, and maybe here to a slightly lesser degree, and then the other states realise that they need to get on board as well.
So that's the following. Another question. So we're getting questions online. So online, please send them through, and I'm getting them sent here. We've got more providers, GP, nurses and pharmacists. How come we haven't got an increase in rates?
Again, a great question. And I think what this shows is that we need a really multifaceted solution. So, as I alluded to with the, funding for the vaccine for everybody in Queensland, great initiative, but that in itself wasn't a solution. And I think, a huge step forward has been, pharmacies and increased providers. So increased access has clearly made a difference, but again, in itself, it's not quite enough. And, that slide where I listed a whole host of factors, we need to try and address as many of those as possible. If we focus on a small number, then again, it's not going to be the solution. I hope the national strategy, which, looks at all of that and is very comprehensive, and we'll obviously hear more about, will hopefully, look across the board at how we can improve things.
And a bit of politics. Can you comment on what the US government's doing, saying, and is that having an impact in South Australia, in Australia?
Well, I think it's impossible for it not to have an impact. I think, issues like some of the commentary there and, what's happened with some of their regulatory bodies and what's propagated on social media has to have an impact here. And, I think that's where, we obviously can't change what happens there. But what we can do, I guess, is just try and make sure we counter any misinformation or anything that we don't necessarily align with being really proactive with good quality information. And I think that's something that we can step up, is try and, actually get more good information out there to counter some of the challenging information that's coming from certain places.
So a couple of questions I'll put into one to you. One is a 66-year-old comes and says, I take my bio drugs and do all the healthy things. I run kilometres every day and I'm so healthy. Why are you accusing me of being incompetent with my immune system? So aren't you insulting me and go away? And when you get specific diseases, how do we make sure that they're people, you sort of alluded to that with some of your ICU and targeted diseases. So how do you balance people who say I'm 65, 70 and I'm healthy, so don't vaccinate me, and others who are so sick they probably should have had it 10 years before?
Look, it's tricky, and I guess that's just about having an individual conversation with those people. And it's clear that risk is not black and white, and that's kind of why I alluded to some of those busy slides that there's a whole host of things that can change risk. So we can't have a blanket guideline for every individual. Guidelines are just that, and that's where I guess people with the expertise like we have in the room and online are just so important at saying you may not necessarily fit, strictly speaking, to this category, but these other factors are a significant risk, and that's why I'd recommend this vaccine for you. So it is challenging and more complicated than ever. But I think, and some people, no matter what you say, will, if they have never heard of that disease or seen someone get sick from it, you can tell them they're at really high risk and they might not necessarily agree. And, we can just make sure we provide them the information and give them access to these vaccines. And if they still don't want to take it, then I guess that's an individual choice. But, that's where I think just having those discussions and trying to educate and inform and encourage as much as we can is important.
Thank you. That's a good wrap up. So thank you. Beautifully done, on time. Thank you very much.